We're talking about slap lesions. It was a horrible operation, and then there were these little absorbable tacks that came out. And they had this bad reaction. Anyway, it's been quite an evolution, and now we've swung the pendulum back, and we're very careful about what we operate on, and I think rightfully so. Um, but our outcomes in our throwing athletes, if we decide we're going to repair labrums, aren't very good. We cause biomechanical changes in these shoulders when we operate on them. If you have an associated rotator cuff tear, as Tom pointed out, the results are even worse. Terrible return to play, 12% in the hands of extremely highly skilled orthopedic surgeons. And slap repairs, like I said, do affect pitching mechanics. So, what about biceps tenodesis? Well, a subpec tenodesis doesn't appear to affect your mechanics. So maybe that's an answer for some of these problems. Our imaging doesn't help us very much at all. There's no correlation really between what it looks like on an MRI scan and return to play rates. So that's kind of challenging. So, we're kind of left with our history and our physical exam to help us make these decisions. And this is a great study from Dave Lintner demonstrating about 50% success non-operative treatment of slap lesions. So, really all of us are taking a non-operative approach initially on almost all of our athletes. Oop, lost it again. Oh, here we go. So why would we leave it alone? Well, it's a purposeful adaptation to physical demands. It's very common in our pitchers, and it does provide increased horizontal abduction and neighbor, which allows guys to generate more velocity, which allows guys to get guys out and allows them to have a higher paycheck. So it's very important, for these athletes. A repair, if you do fix them, you got to be careful. It can undo our normal adaptation, and further tearing from sutures can occur and can lead to some joint contracture. So why would you repair it? Well, it's an important structure. It's an important stabilizing structure in the shoulder. It provides rotational and translational stability of the glenohumeral joint. If you have an acute traumatic injury, you may want to get after that one to repair versus our chronic adaptive changes. And this is very important. There's really no evidence-based publications validating either debridement or tenodesis as a preferred method over repair. So we really don't know. We've got this bucket of options. We're not quite clear as to what we ought to be doing. So the idea of a good slap and a bad slap, this has been popularized by our colleague John Conway, and this is a nice way to think about this. So a good slap would be considered it's a purposeful adaptation of the shoulder that allows for greater rotational motion, allows for greater arm speed, greater velocity, and more success as an athlete. Bad slap is a pathological process that causes and leads to instability, pain, and ultimately lost performance. And in general, we're going to ignore or debride the good slaps, and we're going to fix or tenodese the bad slaps. That's kind of the summary of this. So what if the slap's not the problem? As other speakers have pointed out, there's a lot going on in the thrower's shoulder, like Dr. Potter shared with us. You can see all sorts of things on imaging. What is it that's important here? Just because you see this on an MRI scan, maybe it's the cuff, maybe there's something else going on. So we're not just treating our imaging here. So how do we determine what's a good slap and what's a bad slap? Well, there are things that you can do in the office that will help you determine whether or not the symptoms are actually coming from the labrum and versus something else. So we do a complete physical examination. You can see all the special tests that we can do there. We add our imaging to that, and then we can do selective injections. Subacromial, biceps groove. If we're doing something in the biceps groove, you're better off doing that under ultrasound guidance. So how that exam and those things work out can help us make a decision. In the operating room, there are also some things that we can look at to help us make a decision. So is this a good slap or a bad slap? What you're seeing there up on the right, that's a chronic type 2. That's a peel back slap. That's a good slap. Bad slap is an acute type 4 that involves the biceps anchor point and some extension up into the bicep. So that can be a problem. But there's other things that we look at as well when we're in the operating room to help us make a decision as to whether or not to repair this labrum that we're looking at. So a good slap, Tom just talked nicely about rotator cuff pathology and symptoms. So a good slap would be one that would respond well to a subacromial injection. So A slap lesion, if you inject the subacromial space, shouldn't make your shoulder feel better. And then these patterns that we see down here. So these are all the things that we see with a good slap, and you get that rollback, the smooth margins, and a normal looking rotator cuff. So we're going to debride that. What's a bad slap? Well, subacromial injection doesn't relieve your pain. Pain could be relieved with a biceps tunnel injection under ultrasound guidance. Poor tissue quality and an acute tear. A traumatic injury. So that up in the upper right-hand corner, that's a traumatic slap. That one probably ought to be repaired. And then if you have any internal impingement stuff going on, you might want to consider doing something with your labrum at that time. 2A is a type 2 that's anterior to the bicep. This is an indication for anterior anchors. And this is a problem. That's a very unstable lesion. That one needs to be fixed. So return to play, again, pretty bad outcomes. We're still struggling with improving these. 64% return to play. A couple of other systematic reviews looking at this. Some problems with our old techniques. Clearly, suture knots, if you look at how these things were repaired traditionally before we had knotless techniques, which I'll show you, you can see what these look like. Knots can create problems in and of themselves. Pre-op, the rotator cuff on the left side looks good. Second look, post-op, you can see some injury to the rotator cuff that correlates probably to those placements of those knots that are rubbing up in that internal impingement position. So knotted anchors have been shown to significantly more likely experience postoperative complications to athletes that have had a knotless type repair. What's going on here? So you can see the second surgery. So this has to do with the technique that's being used. And clearly these knotted repairs aren't going to do particularly well. You can just look at that and say, you know what, that just doesn't look like it's very good. So how did we do it before? So way back in the 90s, early 2000s, we'd have transtendinous cannulas, which leads to a superior capsular injury. We put sutures in the front and tie down that bicep anchor point. Hard prominent suture knots, really poor technique, but the best we had at that time. This is how we prefer to do it, percutaneous or small cannulas. Coming in through a percutaneous approach without big cannulas in the front, or superiorly a meniscoid rim debridement. So not an aggressive debridement, not aggressive preparation of the bone. You really want to do that pretty minimally. Again, you're going to want to be careful with putting things in the front. If you have a patient who you feel has anterior instability and has some tearing of their labrum anterior superiorly, then you can put an anchor in the front side, but you want to be careful not to strangle that biceps tendon. The biceps anchor point is a mobile structure, and if you fix that, you decrease their rotation. So you want to be careful with that. And we're using a knotless technique that you can see here. So. And this is what you're hoping to get. These look a lot better than those ones that we used to put sutures in. You can see this is just it's just a cleaner looking repair, a nice way to do it. So what's a bad slap repair? Well, obviously anything that was considered irreparable or a missed bicep tendon or biceps tunnel disease. We can talk about that during the panel today. But if you're missing biceps and you're just fixing the slap, you're probably not doing them any good. So, sort of to summarize this, so we need to diagnose and treat the real problem. So first of all, you've got to make sure that that's what you're dealing with. If you think the labrum is the issue, got to make certain that is in fact the case. For good slap lesions, we tend to ignore those. At most, probably debride them. We're going to repair tenodesis bad slaps. And we're going to make sure we don't miss biceps tunnel disease. So, repair debridement. Well, debridement's always going to be better than a bad slap repair. What about a tenodesis? A good tenodesis is certainly better than a bad slap repair. Really, anything is better than a bad slap repair. So we want to be very, very careful, very thoughtful about which of these we're operating on. Here's a bad slap lesion. This can help us make, this one looks like one that you're going to end up doing a tenodesis on. He's had a unstable biceps anchor associated with biceps tunnel tenosynovitis. He's a bad looking slap. So that would be one you'd probably want to fix. I just want to move through this. So what about labrum repair and tenodesis? I think you want to be very cautious with that. Peter Chalmers has done did a nice study back in 2016 looking at that. And tenodesis plus slap repair leads to a worse outcome from either one of those done separately.